A 66-year-old man, history of ESRD on dialysis, complaining of months of pruritus over his back and arms. That's worse at night. He has no rash, and the pruritus has persisted despite changes to his dialysis regimen and topical treatment. Question is, what is the best next step in treatment for his pruritus? A, diphenhydramine, B, hydroxyzine, C, gabapentin, and D, baclofen. I'll give everyone 20 seconds. I'm seeing some nice pensive looks, which makes me glad I picked this topic. The correct answer is gabapentin, and we're going to talk about that. And if anyone picked that correct, a little pat on the back. So we're talking about uremic pruritus. So the incidence actually is fairly common, people on dialysis, up to 50%. And there's a lot of poor outcomes associated, including depression, poor sleep, decreased social functioning, and also independently associated with mortality, probably not directly from the pruritus itself, but just as a result of people having worsening disease. There's some clinical features that are important. So there's no clear diagnostic criteria, but I think knowing this is typically bilateral, large body part, so it's not going to be a small area, and there's no primary rash. I mean, you may have excoriations, but there's no primary rash. It's often worse at night. And again, think about your population. This is people with either severe kidney disease or ESRD. Pathophysiologically, like, we really don't have a clear idea. There's a lot of thought this is a kind of a type of subclinical neuropathy, but I think a big take-home point is it's not thought to be mast cell or histamine mediated, which means our treatment is likely not going to be helpful if we're targeting antihistamine drug class, and we'll talk about that. So initially, there are some non-pharmacologic interventions. None of them have great evidence, but those include trying to increase dialysis clearance by increasing time on dialysis, or maybe using a high flux dialyzer. People with hypercalcemia, hyperphosphatemia may have worsening of their symptoms. So often talking with nephrology to see if something can be changed is useful, but there's not awesome evidence for these things. So topical therapy, again, there's some evidence. The topical emollients and menthol, there's been no randomized trial, but they're pretty low risk. So these are typically the first things that are tried. Again, helping with hydration, and menthol may help some patients. Capsaicin has small trials showing some benefit. The challenge is it comes back after you stop it. It's hard to apply to large portions of the body if it's a systemic symptom, and some people don't tolerate it. It is important to know that steroids have been studied and have not been shown to be effective, so would not recommend trying steroids. Antihistamines, again, I'm going to repeat this. There's no study showing their use. Despite up-to-date listing it as a possible treatment, there's no study that's ever looked at this as being helpful. And I think part of the reason is that pruritus is not thought to be histamine mediated for uremic pruritus. Second main take-home point is that there is very good data for gabapentinoids being effective for uremic pruritus. So there's been positive RCTs. Again, these are smaller studies, but a fair amount of evidence showing both gabapentin and pregabalin. I'm going to focus on gabapentin because there's a little more data, but they showed a decreased severity pruritus with a relative risk reduction of 0.18. I mean, it's like pretty substantial improvement in pruritus for patients. Like they use the visual analog score. So these are patients who are dropping from like a score of like 8 or 9 down to 1 or 2 often. So really robust improvement when using gabapentin or pregabalin. And this specifically was a pooled analysis of gabapentin and the trials available. So the dosing. So the starting dose is 100 milligrams after dialysis. I think we all know that gabapentin is renally cleared, so you have to be careful. And so this is the way I typically start. The max dose is 300 milligrams daily for people who are on dialysis. And you have to be mindful of patients who have risk for delirium, falls, or sedation. So again, starting low and titrating slowly. Other treatments that are less effective, there's some possible related to opioid modulation. So nalbuphine and naltrexone have some small evidence. UV therapy, cannabinoids, et cetera. I think, you know, again, these are all things that I would not be prescribing, but there are other lines of therapy if a gabapentinoid is ineffective. So in summary, so diagnosis, there's no clear criteria, but thinking about daily pruritus without a rash, that's bilateral in patients who are on dialysis. Pathophysiology, not super well understood, but it's not thought to be histamine mediated. Treatment. So first line is you can try topical emollients or topical menthol because they're almost zero risk. But I think the take home is that gabapentin has been shown to be effective in starting low, 100 milligrams after dialysis, and titrating up to 300 milligrams daily if tolerated, and to avoid antihistamines or topical steroids because there's no data showing that these are effective.